In this session, we're going to discuss about a very dreadful disease that many years back used to be a very big threat to the society. Yes, these infections were caused mainly in the unimmunized children, and in today's world, because of a massive coverage with the immunization, these diseases are very rarely seen. But it is a notifiable disease, and it is important to know the clinical features of these important infectious diseases, that is diphtheria, pertussis, and tetanus. So what is diphtheria? Now, diphtheria used to be a very bad disease many years back, and mortality was almost sure in a patient who got diphtheria infection. It is an acute toxic infection that is caused due to Corynebacterium diphtheria. So, the causative organism is Corynebacterium diphtheria. It is aerobic, non-encapsulated, and a non-spore forming, mostly non-motile, pleomorphic gram-positive bacilli. So, Corynebacterium diphtheria can easily be visualized and identified on doing a simple staining test and also on a glass slide under the microscope. So, this is the morphology that happens and is present in Corynebacterium diphtheria, which can be easily identified. Diphtheric toxin production occurs only after the acquisition of a lysogenic corynebacteriophage by either the Corynebacterium diphtheriae. So once they enter the body, the main mechanism that they undergo is production of the toxins, which are basically the diphtheric toxin. So whenever the virulence is acquired by these Corynebacterium diphtheria, they are capable to produce the diphtheric toxin that goes and cause all the clinical symptoms. The demonstration of diphtheric toxin production or potential for toxin production by an isolate is necessary to confirm the disease. So if it has started to produce the diphtheric toxin, it will definitely result into the virulence and the clinical disease will set up. So it is important to demonstrate the onset of toxin production rather than just the demonstration of the organism in a particular patient. So that is how basically Corynebacterium diphtheria was highly infectious, because the toxin that it used to produce could result into a devastating disease. So how was the transmission of diphtheria earlier? Now, in many years back, the diphtheria was basically an airborne disease. So it was transmitted by the airborne respiratory droplets, and it could easily spread, especially in cases of overcrowding. Direct contact with respiratory secretions of the symptomatic individuals could simply result in the spread of the disease or even the outbreak of the disease. Exudates also from the infected skin lesions could cause the spread of disease. If diphtheria is endemic, then around 3 to 5 healthy individuals could also carry the toxigenic organisms. So even in healthy individuals, if they are living in an endemic area, especially many years back, India was also the endemic country for this infection. So even healthy individuals could carry the normal toxigenic strains inside them. Diphtheria is endemic in India. The skin infections and the skin carriages are usually silent reservoirs. They might just be the silent carriers, and the diphtheric toxin activity is not profound in them, but definitely they are the carriers of Corynebacterium diphtheria. The transmission through the help of contaminated milk was also the cause of the outbreak, and the infected food handlers have been documented in spreading the infection. So airborne infection spreads by respiratory droplets, direct contact with the infected droplets, and also direct contact with the infected skin lesions and with the infected food handlers. These were the methods how the disease got transmitted. So many years back, because of poor sanitation methods, poor hand washing techniques, too much of overcrowding and staying together in slums or in very overly populated areas, led to easy transmission of these infections. Now, children between the age of 1 to 5 years are commonly infected. So, generally, the infection does not happen after 5 to 7 years, maximum till 7 years of age, but from 1 to 5 years of age, it is commonly seen. Herd immunity of 70% is required to at least prevent any outbreak of epidemic. Contaminated objects can easily spread the disease, so all they needed was just the contact directly with the infected organism or the infected organism present in any secretions, any skin lesions. So, direct contact could also spread the disease. Overcrowding, poor sanitation, hygiene, illiteracy, and close contacts led to the outbreak of this disease in our country. So what is the pathogenesis for diphtheria? How does it gain entry inside the body, and what does it do to produce such a clinical spectrum of disease? So the entry happens through the nose or the mouth because it is an airborne disease. The organism remains in the superficial layers of the skin lesions or the respiratory tract mucosa, and in those areas where it is where it has got the first entry of portal, it is going to induce a local inflammatory reaction. So once the air secretions, the air that is being inhaled, which is infected with diphtheria organisms, it gets inhaled inside, it goes and sticks to the respiratory epithelium. Now the mucosa where it is going to stick down, that mucosa is going to get infected, and at that particular area the local inflammatory reaction will start. Now, the major virulence of the organism lies in its ability to produce the toxin. So, now it is going to start to produce the toxin, which is a potent 62 kilodalton polypeptide exotoxin that inhibits the protein synthesis and results into a local tissue necrosis. So, once the toxin starts to produce, the features of local tissue necrosis will start. A dense necrotic coagulum of the organisms can be formed, which will get coated with epithelial cells, fibrin, leukocytes, erythrocytes, and form a very advanced form of grey kind of a brown leather-like adherent pseudomembrane. So one very characteristic feature of diphtheria infection is formation of a pseudomembrane. Now, the pseudomembrane starts with the local inflammatory response, which gets added on with depositions of fibrin, leukocytes, and all the cells and debris from here and there that is coming over it, and it becomes a very thick, leather-like coated kind of a layer that is formed on the respiratory epithelium. Its removal is very difficult, and once we try to remove it, it can produce bleeding also. So, this is a pseudomembrane formation that happens in the disease of diphtheria. Now, apart from that, the local effects of a diphtheric toxin. So, once the toxin is formed, it can get released from that local tissue area after causing tissue necrosis, and it spreads in the whole body. It causes paralysis of the palate and also the hypopharynx. It can result into the onset of a pneumonia. The systemic effects could be, it can go and damage the kidney tubule causing necrosis. It can result into hypoglycemia. It can damage the heart causing myocarditis. And the most bad effect is on the central nervous system, where it causes demyelination of the nerves resulting into paralysis. Myocarditis can happen 10 to 14 days after the onset of this infection. And demyelination of nerves can happen even beyond 1 month, that is around 3 to 7 weeks of the disease. So the last complication to occur is the central nervous system complication. It can also cause a clear-cut cardiac involvement in terms of myocarditis, and definitely the local tissue damage and the paralysis of the palate and hypopharynx can occur. So what are the clinical presentations of diphtheria? What are the clinical features with which we can clear-cut examine the case and say it could be a diphtheria? Because it is a notifiable disease, it is very, very important now to know how it presents. If any time somebody comes across a case of diphtheria, it's important to notify this particular disease. So it is influenced by the anatomic site of the infection, the immune status of the host, and also the production of the toxin. So how much toxin is produced, what is the immunity level of the particular host, and also the site of involvement of the infection. These all come together to actually produce the clinical prodrome of the disease. So the incubation period is 1 to 6 days. Once it get entries inside the human body, it will result into the incubation of the organism. So before it produces the symptom, it can take around 1 to 6 days duration for the incubation period. Now there is nasal diphtheria. So nasal diphtheria is the first manifestation that will happen. So the infection of the anterior nares can result into nasal diphtheria. It causes a serosanguinous, purulent, erosive rhinitis with a formation of membrane. So inside the nose only there will be features of rhinitis. There could be erosion and inflammation resulting into the formation of the membrane. There could be shallow ulcerations of the external layers and the upper lip, which is a very characteristic feature. So again, because the necrosis keeps on continuing due to the exotoxin production, and there's a pseudomembrane formation which if tried to remove can result into bleeding. So this kind of presentation, which ultimately destroys the areas of the external layers and also the upper lip, is a characteristic feature of nasal diphtheria. Unilateral nasal discharge is pathognomic of the nasal diphtheria. So there could be a complete destruction of one side of the nose, which can result into a continuous nasal discharge in nasal diphtheria. Then another type of diphtheria is a tonsillar or a pharyngeal type of diphtheria. So apart from just affecting the nasal part, it can also go down to affect the tonsillar or the pharyngeal involvement. So sore throat is the universal early symptom that is going to develop if the patient is having a tonsillar diphtheria. Only half of the patients can develop an episode of fever. Few of them can also experience dysphagia, hoarseness of the voice, malaise, and even headache. So the common viral type of prodrome that could be seen in the initial stages of a tonsillar diphtheria. Mild pharyngeal injection, which could be unilateral or bilateral tonsillar membrane formation, can also be appreciated. So whichever is the site of damage or whichever area is getting affected due to diphtheria, definitely it will result into the formation of pseudomembrane, because that is the basic pathogenesis of the exotoxin that is released from diphtheria bacilli. It extends to involve the uvula, the soft palate, the posterior oropharynx, the hypopharynx, and the glottic areas. So ultimately, the entire neck region gets affected. Underlying soft tissue edema and enlargement of the lymph node will happen because of the effects of the local tissue necrosis and due to release of exotoxin. And ultimately, it will give rise to the characteristic presentation of diphtheria known as a bull neck appearance. So the neck of the child will become really huge and there will be a presentation of a bull neck sign. So that is a very, very beautiful feature that is seen in diphtheria in one instant examination. If there is a child who has presented with sudden episode of swelling of the neck and sudden episodes of fever, cough and difficulty in breathing, then it is very important to diagnose diphtheria, because the treatment is totally different in cases of diphtheria. However, nowadays we don't see the cases of diphtheria because of such a nice coverage of immunization given by the government itself, but it was a very dreadful disease initially many years back. However, in some places, if the immunization coverage has not happened properly or the children were not taken for immunization, they are still unimmunized, they can develop this disease and they can present in hospitals, because the presentation is going to be with respiratory difficulty. So that might require some kind of mechanical ventilation support as well. So bull neck sign is very, very important to understand. So that is how a tonsillar diphtheria is going to present. So how do we diagnose? It is completely a clinical diagnosis. So by simple examination and a good history, we can easily diagnose the case of diphtheria. Although to elaborate the diagnosis and to actually isolate the organism, it is important to do the culture from the nose, throat and any other mucocutaneous lesions. The portion of the membrane should be removed and submitted for the culture along with the underlying exudate, so that we can grow the culture and demonstrate the organism. Ilex test is used for rapid diagnosis. Again, it can help us to diagnose within 16 to 24 hours duration. Enzyme immunoassay can also be used. PCR for the A or the B portion of the toxic gene, that is part of the gene, that can be used for PCR analysis. So if we are finding a positive tox involvement in that particular specimen, then that means it is positive for the exotoxin of diphtheria. Hypoglycemia, glycosuria, increased BUN, abnormal ECGs, involvement of the liver, kidney and heart. These are all important features which can also help us to make the diagnosis. So basic investigations like a blood glucose levels, liver function test, renal function tests, ECG, 2D echocardiography, all of these can also help us to ascertain the diagnosis of diphtheria. But to be sure, we can grow the culture from the exact specimen or the tissue which is involved because of the exotoxin destruction. So what are the complications of diphtheria? So the most important complication is respiratory arrest that can happen because of obstruction. So respiratory tract obstruction by the pseudomembrane is the most dreadful complication. A bronchoscopy might be needed to evaluate the exact formation, the pseudomembrane, which can be easily visualized on doing a bronchoscopy. It might require an intubation and a mechanical ventilation support for assisted ventilation. Toxic cardiomyopathy is another complication that develops in patients of diphtheria. So tachycardia will happen out of proportion to fever. So that is basically because of the myocarditis that has happened. The inflammation of the heart that takes place as a reaction to the exotoxin produced by diphtheria can result into myocarditis. So if myocarditis is going to be present, definitely the patient is going to develop undue tachycardia. So depending on the degree of fever, even if it is around 99 or 100 degrees, it can result into undue tachycardia. That means the heart rate would be out of proportion. It could be more than 200, 210, 220 also. Prolonged PR interval and changes in the ST-T wave can be seen on the ECG. Elevation of the serum aspartate aminotransferase concentration closely parallels with the severity of the myonecrosis. So on doing the tissue evaluation, we can see it has got an elevated serum aspartate aminotransferase levels. So these are the methods how we can see the demonstration of toxic cardiomyopathy. So inflammation of the heart can also happen. Then another complication is toxic neuropathy. So neuropathy basically means it will go and damage the central nervous system. So hypoesthesia and soft palate paralysis can happen. Symmetric polyneuropathies can involve it can result into paralysis of the limbs as well. So that is a late complication that develops after few weeks of the development of diphtheria. So how do we treat a case of diphtheria? Now, because the entire mechanism is happening because of exotoxin, so we have to decrease the effect of this toxin, so we can give the antitoxin from outside source. So antitoxin is the mainstay of the treatment in diphtheria. It goes and neutralizes the free toxin that is released in the body. The antitoxin is administered as a single empirical dose of 20,000 to 1,20,000 unit. Now, this does not depend on the age, gender or weight of the baby. It depends on the degree of toxicity, the site of involvement and the size of the membrane and duration of the illness. If it is very severe, we can give even a higher dose of this antitoxin. If it is not that severe but membrane formation has happened and we need to decrease the effect of the toxin, then also this antitoxin can be injected. Another method of treatment is the antimicrobial therapy. So we can start erythromycin at the dose of 40 to 50 mg per kg per day 6 hourly, aqueous crystalline penicillin G at the dose of 1 lakh to 1.5 lakhs per kg per day 6 hourly IV, procaine penicillin that is around 25,000 to 50,000 units per kg per day 12 hourly IM for 14 days duration. So a good antibiotic coverage can also help in the treatment, but it is not a specific treatment for diphtheria. Now, apart from treatment, the most important thing is to prevent the onset of diphtheria. It is a highly dreadful disease. It can result into mortality. By the time the parents recognize the bull neck appearance and everything, and they understand something is wrong with the child, it has already resulted into a lot of devastation. So, bringing the child for mechanical ventilator support cannot reverse the disease completely. It might result into mortality as well. So, it is very, very important to prevent the onset of this disease rather than actually focusing on the treatment part. So the asymptomatic case contacts who have come into contact with the direct cases require a prophylaxis with antimicrobials. So again, erythromycin or a single dose of injection penicillin G is going to be helpful to prevent the onset of disease in healthy individuals who have come in contact. Diphtheria toxoid vaccine, that is DPT immunization now, which is given by the government, is very, very important to immunize the children who have not received a booster dose also within 5 years of age. So following the complete step-by-step fashion of DPT immunization, which has led to such a beautiful coverage that DPT now is not at all a problem in our country. However, sometimes some cases can occur. It is a notifiable disease, but the immunization is the best way to prevent the onset of this disease. So every child should receive the immunization of DPT vaccine so that they don't develop these dreadful infections in their lifetime. Moving on to pertussis. So out of DPT, diphtheria is the D part, pertussis is the P part, and tetanus is the T part. So it is a combination of these three important infectious disease that is also given in terms of vaccination, and also it is important to know the clinical feature of each and every disease. So what is a pertussis infection present like? So it is a highly contagious acute bacterial infection that is caused due to a bacilli known as Bordetella pertussis. So it is caused because of this organism. Worldwide prevalence has again decreased because of a good immunization coverage. However, it remains a public health problem among the older children and adults. Some of them can still get infected with pertussis. It continues to be an important respiratory disease in those infants who are not immunized or unvaccinated with pertussis. So how does it get transmitted? Again, it is an airborne infection. So the respiratory route is the form of the infection transmission. That means it gets spread by the droplets. Adolescents and adults are the reservoir for this infection. There is no animal or insect reservoir for pertussis. It is a highly communicable disease. That means even coming in close contact with these droplets or inhaling the suspended particles in the air can also result in the infection. The secondary attack rate is as high as 80% among the close household contacts. In the catarrhal stage and 2 weeks after the onset of cough also, it can result into spread of the infection. So Bordetella pertussis is a very important organism. It can be also visualized and clearly we can see the evidences of this infection if we isolate the specimen. It is an aerobic gram-negative cocobacilli. It produces the toxin known as the pertussis toxin. Now it is a filamentous heme agglutinin along with hemolysin, adenylate cyclase toxin, and demonecrotic toxin and tracheal cytotoxin. So it has got many different types of toxin, and once it is released in the body, it will go and act on the different tissues, resulting into local inflammation and necrosis and further spread of this toxin through the route of blood. So it can spread in the entire body, resulting into clinical features of pertussis. It is responsible for the clinical features, that is toxin mediated disease. So like diphtheria, again pertussis is basically all because of the toxin that is released by the organism Bordetella pertussis. Now this toxin has got many components. The most dangerous part is the heme agglutinin, so it can result into sudden episodes of bleeding as well. However, the complications depend on the amount of toxin that is released. So it has got heme agglutinin, hemolysin and many other components which can be very bad for the complications. It can result into many complications once released inside the bloodstream. So what is the pathogenesis of pertussis? How does it spread basically? Now the organism gets entry with the help of the droplet infection. Once it is inhaled inside, it goes and attaches to the respiratory cilia, and toxin causes the paralysis of those local areas, the cilia that is present over there. It produces a mucopurulent secretion, that is basically a serosanguinous exudate that forms in the respiratory tract. So once this exudate has started to form, it predisposes to atelectasis, frequent episodes of coughing, cyanosis and pneumonia. The organism causes local tissue damage and systemic effects, which is mediated once the toxin from that local tissue damage goes and spreads inside the blood. So it can get released from there and it is going to affect the entire body. So the local area gets completely damaged. It can result into coughing episodes, production of sputum and result into a very bad pneumonia episode. So what are the clinical presentations? So once it enters the body, it requires an incubation period of around 7 to 10 days. So after the entry inside the body with the help of droplet infection, it takes around 7 to 10 days for the incubation. The infection can last as long as 6 weeks to 10 weeks. So it produces a very chronic course of cough. Coughing does not resolve at all. It can be very prolonged, like even 3 to 4 months it can go up to that duration. So in the stage 1, it has a catarrhal stage which lasts for around 1 to 2 weeks. It presents with a normal viral illness kind of symptoms like coryza, sneezing, redness of the eye, coughing episodes and fever episodes. In the stage 2, it results into a paroxysmal coughing stage that can get prolonged up to 6 weeks of duration. Due to difficulty in expelling the thick mucus at the end of paroxysm, long inspiratory efforts is followed by a whoop. So because there is so much of mucopurulent secretion that is happening and local tissue damage, that it causes that paroxysm bouts of cough. But however, at the end of the paroxysm, the child tries to have a long inspiratory effort which is followed by a whoop, and that is why pertussis is also known as a whooping cough. So it is also known as a whooping cough disease because that is the characteristic presentation that is happening. The pattern of coughing is like a whoop. Then comes the stage 3, which is the convalescent stage. It is a period of gradual recovery which can take even as long as 5 to 6 months duration. Then coming to the complications of pertussis. Now pertussis mainly attacks the respiratory system, so it can cause secondary pneumonias resulting into apneic spells, causing even cyanosis. There could be certain neurological complications because of the exotoxin that is released. So it can cause seizures, encephalopathy, hypoxia, and even cerebral hemorrhages. So bleeding manifestations are seen in pertussis because the exotoxin that is released has got hemolysin also as a toxin. There could be otitis media, anorexia, episodes of dehydration, rib fracture. There could be pneumothorax, subdural hematoma, hernia, and even rectal prolapse. So pertussis can go and infect any of the systems of the body, but the primary focus is on the respiratory system, resulting into a very bad pneumonia causing apneic spells and also the onset of cyanosis, followed by CNS damage. So it can result into seizures, encephalopathy, any episode of hypoxia, and even bleeding. Furthermore, it can infect other various organs of the body. It can cause GI complications like a rectal prolapse. It can cause hernia. It can cause bleeding elsewhere in the body, and also episodes of anorexia, rib fracture, and pneumothorax because of the respiratory involvement. So that is how it can complicate. So how to diagnose a case of pertussis? Now it is basically again a clinical diagnosis. So if whooping cough is there along with a history of mild grade fever onset, then it is a diagnosis of pertussis. It is suspected on the basis of history and clinical evaluation, but to confirm, we can do a culture, genomic, and even serological evaluation. Now, one very important way to diagnose it is extreme elevation in TLC counts on a simple CBC evaluation. So, if we send the blood hemogram picture and there is elevated WBC count, that is extensive lymphocytosis is there, more than even 20,000, 30,000 TLC, along with this classical clinical history, it can definitely help us to make the diagnosis of pertussis. The absolute lymphocyte count can go up to 20,000, which is highly suggestive. Now, to culture the organism, the gold standard is especially in the catarrhal stage. So, to isolate the organism when the person is highly infective, at that particular stage, we can take the specimens and we can culture out the organism. Saline nasal swab or swab from the posterior pharynx is preferred because that is the site of inoculation for the organism. PCR can also be done, which is the most sensitive test to diagnose it, which can be done even after the antibiotic exposure. So even if minute traces of organism is present, the polymerase chain reaction can grow it and we can demonstrate the organism, that is pertussis. So the treatment of pertussis, the most important thing is to get relief from the coughing episodes. So avoidance of any irritant, smoke, noise and other cough promoting factors is very important. Antibiotic therapy can help in relieving the cough episodes. So erythromycin, again 40 to 50 mg per kg per day, 6 hourly orally for 2 weeks is advised, or azithromycin 10 mg per kg for 5 days in children who are less than 6 months of age can be used. And for children more than 6 months of age, 10 mg per kg per day on day 1, followed by a dose of 5 mg per kg per day from 2nd day to 5th day is advised. Another drug which is commonly used is clarithromycin. So clarithromycin again at 15 mg per kg 12 hourly for 7 days can be given. So this antibiotic therapy can help to treat the mucopurulent discharge and secretions and the coughing episodes. Supplemental oxygenation, good amount of hydration, cough remedies and also bronchodilation can be helpful in certain individuals. So that is how we treat a case of pertussis. Now again, because it is a highly infectious disease, rather than treatment, we should try to prevent the onset of pertussis. So for prevention, all the household contacts should be given erythromycin for at least 2 weeks so that they don't develop this disease and further infect other healthy individuals. Children of less than 7 years of age not completed the 4 primary doses of immunization should complete them at the earliest. Children less than 7 years of age completed the primary vaccination but have not received the booster doses in last 3 years should also be given a booster dose. So a complete immunization against DPT, that is very, very important to prevent the spread of these kind of infectious diseases. Now moving on to the third dreadful disease, that is the tetanus. So tetanus is also very, very bad disease. It is a very acute, fatal, severe exotoxin mediated nervous system disorder characterized by episodes of muscular spasm. So tetanus is basically muscle spasm that happens. It goes and damages the central nervous system and it can be very acute onset and also it is a fatal disease. It is caused by the toxin produced from the anaerobic organism, that is Clostridium tetani. So C. tetani is the causative organism for tetanus. Tetanus is the only vaccine preventable disease that is infectious, but it is not contagious from person to person. So it will not spread from an infected person. If somebody has tetanus, if somebody comes in contact, it will not spread directly from person to person. And it is the most important vaccine preventable disease. A simple dose of tetanus toxoid immunization can prevent tetanus. Clostridium tetani is part of normal flora inside the human and animal intestine and is disseminated through the excreta also. However, it is mainly found in the soil, and contaminated soil into the wound or contaminated soil getting inoculated in the bloodstream can result into the infection of tetanus. So contamination of wound, any unhygienic and improper handling of the umbilical cord in the newborns is very, very important. Lack of hygienic habits and aseptic care during and after delivery are the main risk factors for infection. So mainly the neonatal tetanus becomes a very, very devastating disease and that is what should be prevented. So neonatal tetanus can happen if the umbilical cord is not handled with care. It is infected with the help of any inoculation with Clostridium tetani because it can spread with the help of soil contamination. It can also spread with dirty hands as well. So if that is going to happen, it can result into easily acquiring this disease in neonates. So that will cause a neonatal tetanus. Apart from that, also if somebody is not immunized and the bloodstream gets infected with Clostridium tetani because of soil or any kind of dirty hygienic habits, resulting into inoculation of infection straight away in the bloodstream, can also result in the onset of tetanus in older children. So what is the pathogenesis? How does it spread basically? So tetanus occurs when the spores of Clostridium tetani found inside the soil, they get access to the damaged human tissue. So whenever they are able to inoculate inside a damaged tissue, it can result into the onset of pathogenesis. After inoculation, the Clostridium tetani transforms into a vegetative rod-shaped bacterium and produces the metalloprotease and tetanospasmin. So the important toxins that are produced is tetanospasmin that goes and acts on the central nervous system. It goes and reaches the spinal cord and the brainstem via the retrograde axonal transport mechanism. So it is going to travel retrograde and then it gets transported to the site of action. It binds tightly and irreversibly to the receptor, and the tetanus toxin blocks the neurotransmission over there. So tetanospasmin that is produced is going to block all the signals of the nerve transmission, causing a blockage of the neurotransmission at that particular level. The net effect is disinhibition of the anterior horn cells and autonomic nervous system. So the anterior horn cells get infected and they stop the neurotransmission. So there is not going to be any nerve generation. There's not going to be any nerve signals that can travel down. It results in increased muscle tone, painful spasms, and widespread autonomic instability. So the overall tone of the body increases. It is not able to receive the response from the central nervous system. So clinically, how will a patient present if that patient has got tetanus? So the incubation period is around 1 to 8 days. Once it gains entry, it takes around 1 to 8 days to go and infect the central nervous system, that is the spinal cord, to block the neurotransmission at the level of the anterior horn cells and result into the clinical features. Generalized tetanus can present with trismus. So the presenting feature is trismus. Trismus basically means minute increased tone of the body, especially it can start from the face. The symptoms of autonomic overreactivity such as irritability, restlessness, too much of sweating, undue tachycardia, cardiac arrhythmias can happen, labile hypotension or hypertension, and fever episodes. So all the autonomic instability will start in the body. There could be features of palpitations, restlessness, tachycardia. All these things can be felt by the patient. Tonic contraction of the skeletal muscles, so it can result into a stiffness of the neck. There could be abnormal posturing of the entire body, so that can attain a position of opisthotonus. There could be rhizus sardonicus. So complete contractions of the body can happen starting right from the face. It can involve the entire trunk. It can also involve the arch of the back and also the abdominal parts. So they can have a board-like rigid abdomen as well. So tonic contraction of the entire muscle system of the body can develop. Painful spasms which is triggered even by loud noise. So any kind of disturbance in the stimuli can result into sudden onset of painful spasms of the muscles or any other sensory stimuli such as a physical contact or light. That is why patients who have tetanus are isolated into isolation ward where the environment is very calm and composed. There is no any kind of stimulus like light stimulus, any kind of noise stimulus, because with this stimulus also it can result into sudden onset of painful muscular spasms. Neonatal tetanus, however, can present with features of rigidity. There could be spasm, trismus, inability to suck, and sudden episodes of seizure. So the tone of the body also increases in cases of neonatal episodes of tetanus. So it's a very dreadful disease and the treatment is very, very important. So first thing is very important to give a very calm and ambient environment and to give a ICU care to the patient who has got tetanus. So it is best managed in the ICU, as the child may also require an early and aggressive airway management. So because of the increased spasm of the muscles, the breathing pattern can worsen, resulting into requirement of assisted ventilation. Wound debridement must definitely be done because that is the site of inoculation which has caused the spread of the disease. Antimicrobial therapy, only metronidazole or penicillin G can be given for 7 to 10 days duration. However, its effect is still not documented in the treatment of tetanus, but it is definitely said that it can result into improvement of clinical features. Neutralization of the unbound toxin is very important. So the entire mechanism is why? Because there is release of toxin, tetanospasmin, that is causing all the blockage and the neurotransmission problem. So neutralization of this unbound toxin by giving immunoglobulins 3000 to 6000 units intramuscular, equine antitoxin around 1500 to 3000 units intramuscular or IV, and also to keep the patient sedated is very important. So diazepam can be used to keep the patient sedated and allow the action of these antitoxins to go and further block the action of the toxins formed in the body so that the mechanism can be reversed. Endotracheal intubation, tracheostomy and nutritional support, physical therapy as soon as the spasm have ceased is also very important. So supportive therapy and specific therapy both are very important in the management of tetanus. Again, it's a very dreadful disease, so it's more important to focus on prevention rather than treating these cases. So prevention is very simple. Just take the immunization and proper treatment of wound and traumatic injury. So whenever there is any doctor who is handling any kind of dirty debrided wound in the patient, road traffic accidents, it's very important to give the dose of tetanus toxoid and also do it in a complete aseptic manner. So any kind of wound debridement that is being done which has direct contact with the bloodstream, so dirty inoculation of soil or any particle could be infected with Clostridium tetani, which can result into the onset of tetanus. So immunization and also clean hygienic methods to handle open wounds is very important. So the prognosis for disease, average mortality of tetanus is high. It is around 45 to 55%. Neonatal tetanus could also have a mortality of 60 to 70%. So most important factor influencing the outcome is the supportive care only. We cannot reverse it completely, we cannot treat it completely and make it normal, but yes, to some extent neutralizing the effect of toxin can treat the further complications and help in relieving the muscular spasm. So it's more important to prevent the disease rather than to take it a chance to actually treat it. So prevention is very simple, just by simple immunization of tetanus toxoid. So for prevention, vaccines are available. So DPT vaccine is the most important vaccine that is going to help children get prevented from these three important diseases. So DPT vaccine is given as 3 primary doses starting right from the 6 weeks of age. The first booster is at 16 to 18 months of age. The second booster is received at 5 years of age, and at 10 years of age a dose of Tdap, that means basically it is tetanus, along with small doses of diphtheria and pertussis can be given, or TD can be given, followed by TD doses every 10 years. So after each 10 years a minute dose of TD is recommended. TD is basically, again, the main component is tetanus toxoid and a small amount of diphtheria is given. So this is going to help in immunization and formation of good amount of antibodies against these dreadful diseases. Catch-up vaccination is also very important. So those children who are not immunized with the primary doses below 7 years, DPT can be given at the duration of 0, 1 and 6 months. So catch-up immunization again becomes important because those who have missed the primary doses, they can still be immunized up till 7 years of age. So that can also help in improving the outcome of these diseases. So the summary for this topic, so diphtheria is an acute toxic infection caused due to Corynebacterium diphtheriae. It is transmitted like an airborne respiratory droplet infection. It presents with bull neck and white membrane over the tonsils, which is the classical presentation. It requires prompt diagnosis and management since it is very contagious. Pertussis, also known as a whooping cough disease, is seen only in children, especially less than 5 years of age. It is caused due to Bordetella pertussis. It presents with features of whooping type of cough and needs to be diagnosed clinically. A hemogram is highly suspicious of a increased TLC count, that is hyperleukocytosis is seen. Tetanus is caused due to Clostridium tetani that can spread because of wound contamination, and it can also result into neonatal tetanus if the umbilical cord of the newborn is not handled aseptically. It needs to be diagnosed clinically and requires an ICU management and a dose of antitoxin to neutralize the effects of toxin released by tetanus. So that is how we can prevent these diseases by a good immunization coverage. However, we should also know the clinical features and the presentation of these disease because in unvaccinated individuals it can still present inside the country. So the classical clinical presentations and the basic treatment is definitely very important for diphtheria, pertussis and tetanus.